evening everyone. So this is a slightly unconventional paper. It's not a study, it's a technique. So as a PG student, I used to find this extremely daunting, and I was taught needle CCC, cystotome CCC, which was extremely comfortable for me. So for me to break out of that took a really long time, because I found doing all my cases with needle CCC quite comfortable. But the day when I had to use a microrhexis forceps for the first time, it took a lot of effort from my side, and eventually it ran away. So Professor Howard Gimble and Professor Thomas Newhan introduced this concept for us, which is a very critical surgical step in cataract surgery that involves creating a smooth circular opening in the anterior lens capsule. Now, CCC is such an important step, so is every step to make a phacoemulsification surgery successful. But this is what centers the whole surgery. If the CCC is small, it can lead to a domino effect of one thing going wrong after another and lead to the downfall of your case. So this is a cystotome CCC. I'm using an image-guided technology to guide the CCC dimensions. So this is a 5.5 rhexis that I'm trying to attempt. Now here I have done it at a 170-degree angle because I'm trying to implant a toric IOL. I have gone directly through the main incision. Viscoelastic egress is present but minimal. I still prefer to choose a cystotome over this because I was not confident about my forceps rhexis, and I managed to do it well. So it was still 5.5, so why the need to switch? Now, benefits of cystotome CCC: you can go through a very small incision, it is held close to the tip, there is much greater control is what we feel than a case of rhexis or microrhexis forceps, as opposed to the steel or titanium forceps. Now if you have a shallow chamber, you need a different angulation. If you have a deep chamber, you need a little different angulation of the cystotome, which I can bend according to my need. But I can't do that with the forceps. I'll have to bend the forceps or modulate the way I'm holding it. Benefits of forceps CCC. Now when it comes to hypermature cataracts where the turgidity of the bag is not that great, when it is weak, the bag is weak, when the pressure of the bag is not that great, the posterior CCC creation, extending a small size rhexis after IOL implantation, I had to pull a runaway rhexis using Little's maneuver. This is when forceps CCC comes in play. Now there is a tip to manage the initial tear, which is to not make it very long. If it is around 1.5 mm, it is going to extend 2 to 3 mm beyond, so keep that in mind. It involves the use of specially designed forceps to pierce and grasp and carefully rotate in a circular motion. It offers better control over the flap, allowing the surgeon to feel when you're pulling. It is a shearing force which is used rather than a tearing force which is used in CCC, so you can easily pull it towards the center if it's suddenly running away. Now, why does it stand out? It offers tactile feedback, allowing us to take a feel of the flap itself rather than trying to push it against the nucleus. Now this is a CCC with the forceps. You can use a corneal rhexis marker as a guide as a beginner and try to center the rhexis around it, make an incision. There will be minimal viscoegress depending on the type of OED you use, also the pressure that we apply on the posterior lip of the incision. Not to enter straight but to enter diagonally, that always helps. And it is important to know that the width of the incision is 2.2, cannot open the instrument completely, that will lead to more viscoegress. Enter slowly, and then if the patient is uncooperative in some cases, better to block initially when you are using the forceps for the first time so that you can get a hang of the instrument first. After that you can go on for topical cases. Even then, if there is an issue, then you can use a secondary instrument to stabilize the eye. Like this. So once the eye is stable, you can grasp and re-grasp at the point of initiation. So always grasp close to the leading point, and that will complete your rhexis. So viscoelastic escape is more with forceps, obviously because using the main incision. Control is more with forceps once you master, but both techniques are very important to use. Transitioning to forceps, you should remember these important points. Visualization in initial cases should be good. Don't choose a small pupil, don't choose a cornea which has opacity. Put adequate viscoelastic, don't feel the need to complete the case with one injection. Come out and re-inject, but not too much. And stain the capsule and use a ring rhexis marker. So start with cystotome because it gives you a good control. Then you move on to forceps because you need another technique in your bag in case you're not, in case the rhexis is running out, it's easy to pull with the forceps. Gradual transition is the key. Chamber dynamics and hand stability, the more you practice, the better it will get. Thank you.
Thank you.